If I have something in my calendar for a dinner appointment and I put the location, Google gives me an update ahead of time saying, hey, this traffic is heavy, you need to
Yeah,
start now. I don't get the same sort of notification when I have a doctor's appointment unless
yeah.
I put an address in. So what I'm trying to get at is we need better systems to remind people why they need to do the things that we're recommending they do, why it's important for them to show up for this appointment because four other people were waiting for the same appointment. They're now not coming or not able to show up.
What we figured out over the last 2.5, 3 years is a lot of the systems that have been built out, the EMRs, the processes, they were taped together very quickly on foundations of technology that are very outdated right now, which means there are systems that are super closed. There's 6 or 7 different conflicting systems that you have to look into to be able to even schedule that single operation. The question is, how do you plug in the gaps right now with the infrastructure? Because it's very difficult to remove the base infrastructure. You have to work with it to be able to improve this.
Mhm.
Voice AI agents is going to unlock a lot of additional capacity across front office admin staff, hopefully even trickling down to physician capacity, nursing capacity. Hello, welcome to 100MS Live podcast where we talk about everything AI and healthcare. We speak with leaders in patient access, revenue cycle, leaders on the clinical side to understand systems and processes that they've built and how they see AI coming into these systems. I'm Aniket, one of the co-founders of the company. We build voice AI agents for healthcare operations. Now, I've been on the technology side most of my life, building out super large scale live audio video systems at Disney, at Meta, and now at 100MS, where we power billion minutes of telehealth calls. And while building these systems over the last 4.5, 5 years, I've just found healthcare fascinating and complex. Like we entered from the technology side, but every time we go in, we unlock how complex just healthcare operations are. And the object of this podcast is to be able to surface some of the most interesting conversations we've had, talk about what are the bottlenecks and issues within healthcare operations right now, and where AI can help unlock some additional capacity or help improve efficiency. And for this, I'm super, super excited to have our guest for today, Dr. Latha Alaparthi. She's been a practicing gastroenterologist for 24 years now. She's currently the associate CMO at Yale New Haven Hospital, their Bridgeport campus. In the past 2 years, she co-founded Olvi Health, which is now part of Pandora Health, focusing on women's health. She was the president of the Digestive Health Physicians Association, the largest gastroenterologist private practice association in the country. She was the chair of the Women's Leadership Council at AGA. Most importantly, for this conversation, she was the first person who clued us into the issues plaguing healthcare operations, including scheduling, which we'll talk about a lot today. She's spent a lot of time overseeing efficiency of operations in clinical settings, both in clinical practice and surgical centers. And I'd love to be able to surface some of her insights, the work that she's done. Thanks, Lata, for coming on board. Super excited to have you here.
Thank you. Thanks for the invitation, Aniket. And it's been such an exciting journey the past, I believe, 6 months now since I began working with you and Kshitij.
The conversations with you are something that we always look forward to. But I'm curious about this. You're a practicing physician, you have responsibilities at the health system that you're currently working at. Why take out the time to interface with tech folks like us?
Many people reach out to us on LinkedIn. And when Kshitij reached out, something was intriguing about the company. And one of the things that's been a burning question in my mind is why am I not at the journey of building something that actually can help solve it from the inside out rather than me fixing it after it's been built? And to that end, I believe physicians and all healthcare practitioners should have been part of the
Hmm.
whole movement for EMRs or EHRs and building the software part of it from the beginning. I think we probably are 20 years too late into this, but it's never too late, as everyone will say. Now, it just makes it harder to now reinvent the process, but I do think that we can do a lot, especially since we're in a crisis moment for healthcare.
Talk to me about why this is a crisis point for you.
We are in a significant shortfall with healthcare providers or clinicians that can help deliver care for patients in need. We also are at a point where there's a record high burnout in healthcare providers from all of the cognitive burdens. I mean, you were hoping about 20 years ago or so when EHRs came into effect that you would actually decrease the burdens, but that's only increased our burdens of having to remember that click and this click. Some people just click away without even paying attention to what they're clicking because we are just so inundated with all of the steps we have to take to do one task.
And this sentiment feels like it's being echoed across the board. You go to healthcare, you speak to CMOs, you speak to CIOs, you speak to CEOs. The urgency with which efficiency or technology is being adopted within healthcare now, whether it's unlocking, let's say, front office admin staff capacity, physician capacity, nursing capacity. We've had the privilege of being able to sell to a bunch of other sectors, but it's been super surprising at how urgently and how openly US healthcare has adopted it. And that speaks to, I think, the urgency of the problem. But it's also reflective of what we figured out over the last 2.5, 3 years is, as you said, a lot of the systems that have been built out, the EMRs, the processes, they were taped together very quickly on foundations of technology that are very outdated right now, which means there are systems that are super close. Providers still send faxes to each other for something. There's 6 or 7 different conflicting systems that you have to look into to be able to even schedule that single operation. The question is, how do you plug in the gaps right now with the infrastructure? Because it's very difficult to remove the base infrastructure. You have to work with it to be able to improve this. And we'll talk about this. One of the things that we figured out over the last 6 months while we've been working with you is AI is now at this frontier where we are unlocking fully autonomous voice AI agents. Essentially, AI agents who can pick up the phone, look up a referral, call up a patient, schedule an appointment with them. A lot of the efficiency gaps within healthcare effectively boils down to how many people can you hire to run these operations and how well can you implement these operational procedures, whether it's docs, whether it's in your EMRs, and get these folks to implement them with 100% accuracy. Now, the moment you get voice AI agents to do this, it's becoming a proxy for implementing the most efficient operational procedures. It's AI agents you configure once who will do the job exactly according to the rules that you've talked about, put stuff into the systems exactly as you imagine them to be. But we believe the voice AI agents is going to unlock a lot of additional capacity across front office admin staff, hopefully even trickling down to physician capacity, nursing capacity.
Now, I think those are all great points. And one of the things you just mentioned is a checklist of questions or aspects that you have to check. Humans are only as good as they can be. And there are times where we all tend to forget one thing or the other unless it's ingrained into our brain in terms of what that checklist is, or each time you have it in front of you and you're literally checking off of that checklist.
Yeah.
I know it's much easier with the technology and the AI operating system rather than a human to go through that checklist each time. But the other point you really hit on is the shortage aspect of it and employee or workforce management aspect of it. I do believe that is significant need for healthcare employees, medical assistants, schedulers, etc. There is a significant need for those individuals to be doing what humans need to be doing, either helping that patient through that day, helping with their anxiety, or answering questions that a scheduling bot cannot do. But I don't think they need to be doing the things that can be automated. And that's how we should be thinking. What can I automate that this individual is doing? And what can this individual do that actually is more intellectual and human level function?
You can essentially have these people spend more time in front of patients as opposed to behind phones doing mundane tasks. There's a bunch of downstream effects, but let's just talk about what's the impact downstream because of, let's say, not the most efficient scheduling operations within the practice or healthcare system.
The numbers change time to time, and it's very easy to find the information, which is that 10 to 30% of general medical appointments are no-shows. And in psychiatry, it's significantly higher. We know that there is a crisis of mental health needs these days, and we have significant shortage, yet 30 to 50% of the appointments go unused. And 19% of primary care. And we all know how difficult it is to find a primary care appointment. And there are about 15 to 20% of physicians available slots that are unused because of various scheduling inefficiencies. About $150 billion annually is lost on no-shows and inefficient appointment use. And each appointment ranges between $200 to $500 for the provider. And if it's a surgical procedure, that is so much more. So in the end, I believe fixing this, even if we can significantly reduce this, we will have done so much good for people that need appointments, for physicians' times, for the revenue aspect of it.
This number comes up constantly. Like you will have physicians losing 60 to 120 minutes a day due to no-shows, scheduling gaps. This is an insane number. And we think a lot of it can be reduced with the use of technology. If you could just help us take us through the process of scheduling in your context, for example, at your practice's context, just take us through all of the details, and then maybe we can go through where do these bottlenecks or issues come from.
Yeah, speaking from my own subspecialty, a person can be referred for a completely normal, no health issues for a screening procedure because they're of a certain age. And also other appointments, such as office appointment, a person may be recommended to come into our office, from heartburn to inflammatory bowel disease to liver issues to a pancreatic lesion to other things. So the way at least the few organizations and groups I've talked to, and we were also part of a best practice group many years ago, is you ask each physician what their subspecialties are when they first join your group. And also you try to encourage them to develop a niche within the group because we're all gastroenterologists in the end, but we all have specific niche areas that we focus on. So for example, you could be doing a manometry or motility studies, and if somebody needs that study, then it's that physician that will see that patient. So when a referral comes in, the checklist verifies what the symptoms are, what was the doctor's referral for, and what's their insurance. How old are they? Because there are some individuals that will only see adult patients and not pediatric patients, and there are
Mhm.
pediatric gastroenterologists. And are they employed by a hospital or not? Because some hospital employees only go to certain hospital locations for their procedures. These are
Yeah.
some of the simple questions we would ask in the beginning. And geographic locations, where they live, et cetera, of course, are a whole nother logistical questions.
Now, depending on these questions, the scheduler who's doing this, do they have then some kind of rule set saying that, oh, if these are the answers, then you schedule with this particular physician, or in this case, you move them for a procedure? How does that work?
Exactly. That's pretty much how it works. But there were also some questions we would ask to expedite the appointment. For example, if we have concerning symptoms, if someone says, I have significant abdominal pain, or I'm losing weight, or I have these symptoms that my doctor said I have to be seen within a week, those appointments are expedited. But for the others, we usually create a list of symptoms, specific symptoms to ask to know which doctor's schedule you need to open up and look at. And then you match the other aspects of questions and then find an appointment.
Even while you've outlined, I think, just the initial basics of this process, this feels like a fairly complicated checklist. Every physician has a subspecialty. Every subspecialty has a set of separate questions. Then there's meta questions on geographical location. And I'm presuming, like, if new provider joins, then some of these rules might change. If, let's say, some payer rules change, then some of these rules change. How do you, A, train all of your schedulers or MAs or whoever's doing all of this task, and then how do you implement any change operations once, let's say, you're changing all of these things?
It's not easy because you're training humans and you're changing processes. And every time you change a process, everyone that's involved in that process needs to be notified. So it usually is by sharing documents, emails, free training sessions, etc. But the individual employees were trained on checklists in terms of questions they need to ask and the flow of the patient. What's the first set of questions? What's the second set of questions? If this, then that, sort of a workflow or a flow chart. And also, if there were clear guardrails as to when a question should be escalated to a manager or a physician for the verification process and then taking the next step. So those guardrails were in place to ensure that patients always receive the best direction that they should be, or the safest route of making an appointment. And in terms of how do you update these lists, we actually update it every year in terms of any changes in the physician subspecialties, because some of us retrain in certain things, some of us give up doing certain things, and we actually acquire new skills. So we always updated that list at least once a year. These are lists that can be updated. And to go back to your world, we can create rules and apply guardrails, just like we did in our clinical practice.
What I've realized after talking to a bunch of MAs and schedulers who do this, there are people who'll become experts in a particular location at a particular practice, and it'll just become second nature to them. And that one person becomes super critical. What I realize is there's rules that you can put down, but it's essentially the person who's implementing those rules is what's making or breaking the system in most cases.
Absolutely. I think an efficient scheduler will reflect the physician's schedule. When I worked with certain individuals, my schedule wouldn't be as busy as when I worked with certain individuals because they knew how to fill up a schedule. So that sort of reinforces the point you just made.
How do you actually measure the efficiency of the system? For example, your general office appointment scheduling.
It's not as simple because the new patients are flowing through a new patient process and follow-ups are flowing through a different process. The measurement is usually based on number of people called, a number of appointments made, but that doesn't necessarily mean those are the number of appointments that showed up to the appointment. So the efficiency is just in the outgoing calls, time spent on speaking with the individuals, and the number of people actually booked for an appointment. That's the extent of efficiency
Got it.
measure.
Like how efficient are GI practices or the people you've spoken with in general in terms of these sort of just new patient general office appointment flows?
I would say they're very efficient with similar systems like the one I mentioned to you, but none of them are foolproof just because a lot of variables exist. For example, one of my pet peeves recently is if I have an appointment, I put something in my calendar for a dinner appointment and I put the location, Google gives me an update ahead of time saying, hey, this traffic is heavy, you need to
Yeah,
start now. I don't get the same sort of notification when I have a doctor's appointment unless
yeah.
I put an address in. So what I'm trying to get at is that we need more alert systems. We know we need better reminders. We need better systems to remind people why they need to do the things that we're recommending they do. Why it's important for them to show up for this appointment because four other people were waiting for the same appointment. They're now not coming or not able to show up.
And this comes back to even if the process is defined very efficiently, if you don't have people to do all of these reminders, if your one or two schedulers are filling up their day by going through a list of referrals, calling them one by one without prioritizing, and then just going through that referral checklist, they won't have a lot of time left over to do reminders for the more at-risk patients, do education for the more at-risk
Yep.
patients. And again, that's the reason why you can use AI or technology to unlock some of this capacity.
Absolutely. I think that even if it's a 2-second call, a staff member calls the day off or the day before and says, hey, do you have any questions for tomorrow's appointment? I want to make sure you're coming in. If not, I have a patient that can take that appointment. That will remind the person, one, and reinforce the importance, but also offer them an opportunity to ask questions. And what that also does, which again you can automate, is if that appointment were to be canceled, then you know where, when, and how to backfill that appointment with another person that's waiting.
The simple question here is you have these checklists, you have these potential reminders that you want to send out. And the technology for storing checklists into system obviously exists. Like you can configure, say, some scheduling rules in your EMR, put in hard stops in EMRs. But whoever I've spoken with in at least the clinical setting in more sort of practice settings, feels like most of it is still done on Google Docs or docs that are being shared as checklists. And why not built out as hard stops or rules within the EMR or practice management software or some such software?
My ideal process would be, yes, have a checklist for every appointment you make and have hard stops for everything you want to prevent. That would be ideal. We are overburdened and we are burned out with the cognitive input from all of the information that we have to take in and
Mm.
interact with on EMRs, including hard stops. So sometimes it becomes almost a habit to override these hard stops and go to the next step. And again, as I said, it's not something that people do intentionally, but I think it is almost a reactionary response. Whereas if you have a software that's developed to abide by that hard stop, it will abide by that hard stop because there is no other rule. There is no rule that you set in to be able to override that hard stop. So I think that's one of the areas where you can actually use checklists and hard stops to a better outcome rather than how it is right now. But even to this day, my pet peeve is checklists for everything that needs to be checked every time and a hard stop for any time we need to prevent something.
So when we first met you, you had this sort of slogan even then, checklist for everything, hard stop for wherever you can. And we've gone ahead and just pushed around, hey, do you have a checklist for this? Where are your hard stops? One of the most interesting conversations was with this RCM leader. This is not even on the sort of patient access side, but an RCM leader who said, oh yeah, there are hard stops that I can put in into the system, but having hard stops means there are no hard stops. Essentially, once you put in hard stops, everybody overrides them. We should maybe touch upon this a little bit. Where does the payer or the financial requisites before an appointment or before a procedure comes in? Where do these come into these checklists? Who's doing that within this process?
I think that's when you open up the Pandora's box and realize how complex the US healthcare system is. There is a whole separate department that does verifications, authorizations, etc. For us, at least in gastroenterology, one is the office appointment that you need to verify and make sure that it is the right provider within the network and what is the deductible and all of this information that you are now obligated to share and ensure that the patient is aware and so that there are no surprises when they show up at the window. And the second aspect is the procedural prior authorizations and making sure that the procedure is within the list of covered benefits. Much of it can be done these days, and you do have a lot of transparency and availability of information that can be verified online through shared systems. But those are not easy. Some of them are very slow. So there's a lot of complexity to that. I'm hoping that particular aspect will improve over time. But even with that, I believe we can work towards a more seamless system by incorporating certain steps.
Do you have a wish list? My checklist has 6 or 7 different points. You've talked about reminders, for example,
Mm.
which you wish you could do, but you're just constrained by the staff that you have or the number of people that you have, and you can't actually execute this. I'm trying to think for a new office, just new appointment, office consultation. Are there pieces missing that even in your past practices where you think, oh, I wish I could have had these components within my checklist?
Clinically speaking, I wish as soon as a patient walked in, I would hand them a family history for genetic testing questions. I would have been very informative if they were able to fill all of that ahead of time. That is specific to the visit with me. Everyone
Hmm.
fills out a history, but it's not as detailed and specific to the questions that I'd like to ask. So that's one example. And in terms of the procedure, et cetera, people come in with different types of concerns. If there was a way people could actually see what the process is, and had a demonstration almost of a video or along the lines and generate their questions and ask more meaningful questions when they're in the office, I think that would make the visit so much more useful rather than me gathering the information and trying to answer at the same time. Because oftentimes I felt like people left my office with more questions than answers because they didn't
Hmm.
realize they needed to ask some questions.
This is the interesting piece. This is a more sophisticated, complicated use case that we haven't, for example, gotten to yet, which is somehow educating the patient as they're in that visit. But all of this is theoretically possible right now with either video AI agents,
Mhm.
voice AI agents, give them a knowledge base, tell them what to talk about, and it'll be like a two-way conversation that you can have patients talk through this, which is what was missing. I think the way I look at it, there was some amount of AI that came in that all of us were introduced to using chatbots or when you type something and they'll respond with something. And it was a
Mhm.
little underwhelming as an experience. A lot of people have MyChart app or the hospital portal, but less than 11% will actually book it online. People still prefer calling and scheduling an appointment.
Mhm.
Voice just is the most natural interface in which all of
Right.
these operations actually happen. And people are more comfortable answering questions for a longer time. You can keep on asking them about history, be patient about it, be empathetic about it. Some of the things that we've unlocked, there's this one health system that we've been speaking with, and they have a very simple use case. They get reimbursed more every time certain patients actually pick up their diabetes medications as opposed to when they don't. Now, it's an incredibly difficult thing to follow up with, let's say, a 5,000, 10,000, 20,000 potentially patient body to call them up, check if they've picked up their medications, do some amount of convincing and education about why it's important, and then drive them.
Yeah.
It's all good for their health. And
Yeah.
they have three pharmacists for a 10,000 patient body. You can make as many checklists as possible. Yes, somebody should call them once they're discharged to have them do it, but you won't have the people to do that, right? Essentially.
Right.
But those are some of the use cases that we started unlocking. And I love this question because essentially asking people, what's your dream checklist piece which you haven't implemented yet? I think that just unlocks so many places which can improve patient experience, which can improve outcomes, which can improve financial outcomes. It's been eye-opening for us to implement some of these things.
No, I think that's a great point. And I also want to point out that people are changing. I think more and more people are relying on tech. But what we've learned also is that while we rely more and more on tech, we still also rely a lot on human connection. And to that end, I think you may have seen some studies about the AI chatbots and VR technologies that are actually improving elderly patients' depression, et cetera, by just even talking to them in a human voice. So I totally appreciate your point. But one of the examples I wanted to use was when I was flying to, I believe, Los Angeles. There was a weather-related issue. The flight was canceled. I made a phone call to the airline to try and change my company. And meanwhile, I'm also on the app trying to reschedule. And within a few minutes, all the salient questions were asked by the interactive bot in a normal human language, not very
Yeah,
rigid questions. Hey, how are you? How can I help you? Sorry, I'm still learning. All these questions were coming up, which actually generated some sort of empathy from me for this automated interactive narrative. And I was able to book my alternative flight within a matter of, I think, maybe 10 minutes while I was still holding on the other phone for the other person to even pick up. So I do think that when people opt for these options, there needs to be that option. Some people, yes, will continue to prefer voice, but also another option if they choose to.
yeah.
But if you can incorporate both into one, even better.
Just taking that specific example, that works because it's like an entirely connected system end to end. Like the AI bot or whoever you're talking to at that point of time, not only could it understand you and talk to you in very human terms, but it also had access to real-time, let's say, appointment information.
Yes.
Even if we were to get to this point in healthcare, and I think we are there now, there are certain systems that are closed. For example, when you're trying to connect to EMRs, they're not always very friendly in terms of giving you real-time
Yeah.
information, data dumps, data downloads. If you are looking up, let's say, provider availability sheets, a lot of times these availability slots are not in some system, it's on some sheet somewhere, which is constantly getting updated. The thing is, once you have a voice AI agent or a text chat AI agent who's doing this interfacing, AI is also at that point where they can log into these operating systems as sort of humans would, read all of that information, and then process it to actually talk back to the patient. Essentially, what this means is all of these unstructured, otherwise closed systems now will also become an integrated single system. And that is a very powerful moment because AI can now read computer screens. AI can now read Google Sheets in an unstructured way. A lot of this technology existed even like a few years ago, but it's gotten to this threshold level where all of this can now run at production scale. One of the problems in implementing checklists, what we figured out is every practice, even some physicians will have a very different way of implementing their rule sets or checklists as opposed to someone else. Now, what this means is if every single practice started implementing their own hard stops in their Epic instances or their EMR instances, that's a huge overhead. Like writing these logics is super complicated. But most people are able to articulate their rules over a Word
Hmm.
doc. Now, these AI agents are smart enough to take these rules from a Word doc and also combine it with all of these EMR systems.
Yeah.
Because AI is now smart enough, you can take all of these very disparate sources of information and have that same real-time magical experience. We just need to pull, I think, a lot of people together to implement this change.
I think I want to change my one dream desire to do it. That would be it. Like when healthcare is all connected, every aspect of healthcare about an individual. I go to a hospital and all of the information that pertains to me, it should be centered around the individual, not the entity or
Yeah,
the EMR or a pharma or whatever else. As long as it's centered around me, I think that will be ideal.
I think that point has come, will come very soon. There'll also be, I think, a lot of regulations that will push towards a lot of these things
Yeah.
accelerating. But yeah, that will be the dream if we can get to that
Yeah.
point. That you and I have been working together on is this one AI agent that can do very specifically scheduling, office and procedure appointments, referral screening workflows. And it's a very complex work list, as you said, like with subdiagnosis, preference for patients. Depending on this, the AI agent can call up the patient, ask a set of qualifying questions, and then potentially also figure out places for efficiency. Oh, this person doesn't have family history, is not at risk. Why don't we suggest moving them straight up to a procedure instead of having them come in for an office consultation, saving
Yep.
physician time, making it more efficient? We've actually built this agent out and we can demo like a very simple single path for this. I just wanted everybody listening to actually be able to experience this. We'll leave a link to this agent's recording at wherever you guys see this. But I'd love to play this recording once,
Yeah, I think it's
just
important
so
to give that example so people actually can see what it means.
us. And thanks, Latha, for sort of taking us through those very complicated rules for us to be able to get to this point. But this is one of our most complicated, involved bots. This is just a very quick, small demo of a simple path.
Yep.
Hello, this is Patricia calling from Gray Sloan. I'm reaching out about the referral we received from your doctor for a colon cancer screening. Is now a good time to talk for a few minutes?
Yes, that's fine.
Great, thank you. We just need to ask a few quick questions to figure out the best next step for you, whether we can schedule you directly for a colonoscopy or if you need to come in for a consultation first. It'll only take a moment. May I have your full name and date of birth to confirm we've got the right person?
Sure, it's Kirk Smith, and my birthday is June 15th, 1979.
Perfect. Thank you, Kirk. You're 45, so this sounds like a colon cancer screening referral. Let's start with a couple of questions to assess your risks. Do you have any family history of colon cancer or colorectal polyps in a parent, sibling, or child?
No, nothing like that in my family.
Good to know. Next, are you having any symptoms right now, like rectal bleeding, unexplained weight loss, or changes in your bowel habits?
Nope, I feel fine. My doctor just said it's time for a screening since I turned 45.
That makes sense. How about your health in general? Do you have any conditions such as heart disease, lung problems, diabetes, or issues with bleeding? Are you on any blood thinners like aspirin or something stronger?
Nope, pretty healthy. I don't take any medications regularly, just multivitamins.
Excellent. One last thing, have you ever had a colonoscopy before? Any prior surgeries or trouble with anesthesia?
No, this would be my first one, and no trouble with anesthesia, with wisdom teeth extractions.
Okay, based on what you've told me, you sound like you are a great candidate to go straight to scheduling your colonoscopy. No need for a separate office consultation first. We can get this set up for you now. How does that sound?
Well, that works for me. What do I need to do?
Awesome. I'll pull up our calendar. We'll need about a few minutes to go over how to prepare for colonoscopy and pick a date that works for you. Do you have a preference for a specific day?
Maybe sometime next month?
Let's see. How about Wednesday, April 9th at 8 a.m.? That's about 4 weeks out. We'd have you come to our Main Street office. Does that work?
Yeah, that's good.
Perfect. I've got you booked for April 9th at 8 a.m. We'll send you a packet with all the details, preparation instructions, what to bring, and a reminder call a few days before. Briefly, You will begin preparing with a liquid diet the day before and take laxative the evening before the procedure. Don't forget you need a ride to bring you home after the procedure. Detailed instructions will be coming in email, and you can call us with questions. Do you have an email or mailing address where we can send these instructions? Also, which pharmacy do you use?
You can email me at kirksmith@gmail.com. And the pharmacy is CVS Mountain View.
Excellent. We'll send instructions to kirksmith@gmail.com and prescription to the pharmacy. If anything changes you get sick or start a new medication, kindly let us know as this may affect your appointment. Otherwise, you're all set. Any questions for me before we wrap up?
No, I think I'm good. Thank you.
You're welcome, Kirk. We'll see you on April 9th. Take care.
Look, the patient's now being very cooperative and talking through, agreeing to most of the things that the scheduler is saying in this case. But we've had our agents handle people talking about stuff about why they missed their last appointment, about their life problems. AI is at a point where you can have them follow an agenda, but also acknowledge what the person in front of you is saying. You can modify the voices to be closer to the community that you have. And more importantly, this came from a very simple initial set of rules or like a 10, 12 set of rules that you put down on a document very quickly. But AI agents are smart enough to sort of take these rules in, understand, and then ask the key questions to be able to build this out. There's some amount of sort of manual work that we are still doing, but I think that will go away very soon. But this is one single agent just doing one referral call. You can have a reminder pre-op preparation call for this. Just doing that pre-op preparation call can reduce your cancellations. Just doing this referral call can help you increase your office hours fill up time or no-shows there significantly by always prioritizing the right people, not having them come to the office instead of going to the procedure room. There's a lot of efficiency that can be unlocked just by this single agent. And once you start chaining these agents, one for reminders, one for education, one for post-op discharge, you have this dream sort of operational checklist and hard stops. They will follow all the rules that you wrote and it'll just do exactly what you set them out.
I think it's a little unnerving to know that they can sort of self-generate some of the things they'll do. It almost kind of scary, but I agree that the technology is where I think it is very conducive to how we need to shape it. I'm not sure if 20 years ago we would have been able to do this, but I'm glad that we are at a stage where we can do it and hopefully rapidly enough that we can help with the issues we spoke about, which is the shortage and burnout and the lack of clinical appointments for people. So yeah, this is very exciting, Aniket, and I'm so glad that I ran into you guys 6 months ago.
We are super glad that you first clued us into this set of problems. And we've talked about scheduling a lot, but we've now gotten into the revenue cycle side. We're doing
Yep.
benefits verification. People are on hold for hours, just status of claims, trying to get a prior auth done just before the procedure comes in. Again, stuff that an agent can do, make sure that you're always on time. We've gotten onto the clinical side. We've talked about some medical adherence, but there's so many checklists that every single sort of clinician or healthcare operations person has in their mind. They all know what, if they had a magic wand, they would
Yeah.
want to automate. It's just been very fulfilling building these out and seeing some of these things get into action. One thing that you said, AI agents are not entirely smart enough to take just like a Word doc and completely sort of run
I
with them.
know.
There's some level of filtering and manual input that we put in at that point. What we are also realizing is one of the things that we do, I think, better than a lot of other AI agent companies, or at least what our approach is different, is what we figured out is you actually need engineers and product managers working to implement these checklists and rule sets because you cannot let AI completely run with it, or you cannot have it completely self-serve where the clinician sort of writes a set of rules and just feed it into the AI system and run it.
Right.
You need that little hand-holding layer to make sure that it actually runs efficiently because there's a lot of gaps currently in the middle. So we work very closely to make sure that we have that done. But very, very excited about what you kickstarted with us by getting us onto this problem. And we talked about just new patient scheduling today. I'd love to be able to talk about a lot of the other problems that we've discussed in the past and in some future episode. But Thanks for all of this. Thanks for coming on to this podcast and talking about all of these problems.
Thank you.
Appreciate
Thank you,
coming on.
Aniket. And I'm really hoping that the clinicians that chime in understand the potential of the current technology we have existing. And thanks for keeping me excited about this topic.